Okay, so thank you very much again for joining us. We are in the HIV masterclass, and today's topic is the HIV-associated focal neurological lesions. We start straight with a case scenario, and I would really want to engage you on this case. So you are presented with a 40-year-old man who lives with HIV, who presents with seizures involving the left side of his face, the arm and the leg. And then he also had some post-seizure confusion. His CD4 count is 32. He's not on air. Confirm if you are able to hear me, maybe by typing in the chat. Oh, I'm cutting. All right, let me try and pause and then try to check.
Like this. So when you look at that CT scan, what you basically is you're seeing it's a multiple ring enhancing lesions which are in the frontotemporal area, as you have mentioned. And then looking at the ventricles, so far there is no in hydrocephalus. So it's just basically what you're seeing is those basic focal lesions that are in ring enhancing. So based on the patient and the clinical condition, I will start first in our area here. I will put TB on the top of my differentials, and then the other infective conditions, toxo will also come in my differentials. And then for CNS lymphoma, this is not really typical of how it can look like. And also remember, by being HIV, you are not, you can still get other conditions. And then because the lesions are also multiple, the other neoplastic conditions like MERS we can think of, but for the fact that the infective conditions will come first in our list, looking at like the CD4 count of the patient is down. So basically what you need is correlate with your clinical picture here.
Yes, I'm really happy, in terms of how you are approaching the case, because I saw other comments as well, which were saying, stop seizures, do a CT scan, and then wait, But I can hear in your voice there that you're actually saying there is a place actually for empirical treatment for common things, because also in South Africa, the issue of access for CT scans in rural districts is quite difficult, and these patients might need to be referred to some central hospital where even a radiologist might not be there to interpret the CT scan. So I don't know, what's your take? Should we wait for the CT scans, or what's your in the context of South Africa? Yeah.
Okay, in the context of South Africa, I think in most, even the most rural hospitals, the baseline things like chest x-rays are available. You will have done your chest x-ray to look in case if you have the lesions in the features of TB in your chest, then you will immediately, when you see that, then you will conclude that what might be in the brain, it can be the CNS manifestation of TB. But then when the chest x-ray is clear, like here in your case, I think it is also important. I know that in some places, even when you have a CT scan, most of the time you get a request for CT immediately, that the doctors are afraid of doing the lumbar puncture, saying that they are afraid of coning. And usually, I mean, you can even do other clinical tests, like a test for the papilloedema. If there are no signs like that, then you can maybe do the lumbar puncture, which may show you if then you can come up with some diagnosis. So when the CT scan is not available, I think that's where the dilemma is, because even after doing the CT scan, I will still give you the differentials. I won't say definitely this is toxo or this is TB. That's where the challenge is, that you cannot on a CT scan, not every time that you can be able to distinguish the two. And
Yes.
sometimes remember that this is a patient with HIV. You can even have both disease, both TB and even the toxo being there all in one. And
yes.
even other infections, because remember, the moment the patient becomes immunocompromised, you may find that you have even other infections.
Yes, great stuff. Thank you for that. Yeah, colleagues, I'm hoping you are enjoying and learning as much as you can. Multiple ring enhancing lesions, so that's where we are. So as a problem list, we've got a patient who presents with focal seizures, multiple ring enhancing lesions of the brain. There's an increased white cell count in the CSF, but it's mostly lymphocytes. And then, we classify such patients as having AIDS because of the severe immune depletion in the context of an HIV positive patient. So this is, at the problem list level. I don't know at this point if you based on the discussion we have had, do you colleagues want to consider other additional tests? Because remember, initially you didn't see the CT scan, so now you saw the CT scan, So what else would you like to do? What would you like to do? Are there any additional tests, assessments? I think Dr. Tebe mentioned certain things, but yeah, can you try and type there and let's have a nice discussion around it? Yes, I see Gene Expert, MCNS, you see. So those are things that are readily available, and some of them have a very fast turnaround time. Masabata, you are coming back to the urine lamp for TB. So you also think TB is still a differential diagnosis, and in South Africa, you can never go wrong by suspecting TB. Any other additional things? And think through your differential as well. Gene Expert, yes. Some of the things you proposed, you saw the CT scan, Kaumbo, you are saying an FBC. Some of you, I wish you could raise your hand so that I can hear your thinking as well. All right. One more test, and then we will take it from there. Yeah, so having seen the X-ray, you must be able to exclude certain things, and then include certain things. But I think the approach I've really taken from this presentation is such that you start to strengthen your clinical assessment of patients, taking proper history, doing a proper physical examination of your patient, looking at some of the tests you might have access to do immediately, empiric therapy based on the common things that happen, and then adjusting really as you get your results. Remember, in advanced HIV care, our patients tend to deteriorate quite quickly, and if we are going to always wait before we start treatments for some of the common things, we might actually lose our patients right there. But yeah, so maybe let me, Tembela, I see your comments as well. TB LAM, blood for toxoplasmosis antigen or antibodies. I mean, that's a very important test to do at this point in time, because if you've got a patient who presents clinically, and you suspect a focal brain lesion, the CT scan says multiple ring enhancing lesions, and your toxoplasmosis antibody test comes back positive, it kind of like, it completes the story, such that probably one of the first treatments you would offer your patient it would be your anti-toxoplasmosis treatment, which is quite important. And yes, blood culture is quite valuable. We will get the results probably in the next few weeks, but at least for now, we would actually start treatment and we adjust based on those results. So quite important to take that approach. So just again, as a question to pose, I just want to check this time you're only allowed to select one. I just want to see what your thinking is around this patient. What is the most likely? We will review this question towards the end when I give you more information. All right. I see most people think toxo, maybe neuro. All right, interesting. Yeah. All right. I'm going to stop. We take 30 seconds with this pause, right? So there we are. Most of us think it's toxoplasmosis and then tuberculosis, meningitis. I see Zipporah, you're also typing in that TB is always TB, tuberculosis, but that's fine. Neurocystic psychosis, and then I think Dr. Tebe commented that it's also at that CD4 count, the probability of having more than one condition is still there. So yeah, let's then go through some theory, and I'll be engaging with Dr. Tebe as we continue. But before, Dr. Tebe, what's your prediction?
Hello.
Yes, I'm saying, what's your prediction? What is your clinical estimate? What is the most likely thing we are going to find?
Cerebral toxoplasmosis in this one.
Right. What's your thinking around it?
I'm weighing the two between cerebral toxo and TB.
Okay.
And I have already said that to be based on the CT scan only to say that this is definitely toxo, you won't be definitely sure. You still have to do some maybe serology for toxoplasmosis. And then if you get the results positive, then you can even, by the time even you get the results, you can start treating the patient for tox.
All right. Thank you for that. It's quite insightful. So yeah. So
and again, the other thing to remember, the chest X-ray was already done. Maybe there were no signs of TB on the chest X-ray, so you can. But that, however, doesn't exclude CNS TB that you can even get in isolation without the lung changes.
Yes, thank you for that. And also, in significantly immunocompromised patients, chest X-rays as well tend to look a bit normal even when there is TB because there's no immunity against the bug. So yeah, all right. Thanks for that, Doc. So yeah, so things that affect your clinical suspicion for certain conditions is one, the CD4 count. I always say yes. Our HIV guidelines in the country say you do a CD4 count at baseline, then you do it again a year later, and that's all. We don't use CD4 counts for clinical monitoring of patients anymore. However, the guidelines do have a statement that for patients who are not well, for patients with advanced HIV disease, like a case that is presenting now, it's important to do your CD4 count because it helps you to include or to even exclude certain conditions, right? For example, if this patient had a CD4 count of 500, I tell you, it was going to be a bit more difficult. Probably half the conditions we are referring to, we will start to question whether they should be part of the differential, and we might be looking at common things that are common, for HIV negative patients, right? Because we know toxoplasmosis tends to happen at a CD4 count of less than 100. Primary CNS lymphoma at a CD4 count less than 50. So you see, now we know that his CD4 count is 32. Generally, most of these things are a huge probability. And if on the history you got that he's a known HIV positive male who's taking Bactrim prophylaxis, who's been taking it for a year. Now your toxoplasmosis suspicion, you become a bit, is it? Because remember, cotrimoxazole prophylaxis, yes, most of us, we know about its effectiveness against pneumocystis jirovecii or PCP in the old name, but it's got additional benefits against cerebral toxoplasmosis, right? A quick, rapid blood test for toxoplasma IgG. If that test comes back negative, well, you could still have some acute toxo, which is rare as well. But if it is positive in the type of CT scan we saw, then toxoplasmosis becomes likely. And then as well, the use of ARVs. One, if the patient is on ARVs, you are thinking probably it's an immune competent patient with a little bit higher CD4 count, certain things are rare. But if they have recently started ARVs and they are presenting with fits like the patient we just discussed now, you would be thinking, can this be an exaggerated inflammatory response because the immune system is just getting better? And remember, last week we discussed a deteriorating patient after starting ART, and most of the discussion was around immune reconstitution inflammatory syndrome. So to predict and to know what type of immediate treatments you need to do, proper history is very important, and you need to look for certain clues. You need to examine your patient. You might find clues. You might find fever blisters that tell you that maybe this is disseminated herpes or disseminated HSV. So there's a number of other conditions that are quite common. I found this old publication by the team at VETS, and they looked at 32 patients, that they followed up for almost a year, and they did physical examinations. They did a lot of tests on these patients, trying to look at what are some of the common features of focal neurological lesions in a developing country kind of setting. And what is quite important here is to note that on examination, 66% of patients had focal signs. So focal signs are quite common with focal neurological lesions, but equally, almost a third of patients really, had normal physical examination, right? And then I think Dr. Tebe was referring to, the effort to really take history, examine, and do some of the common investigations that are within, your reach, because 60% of these patients had non-neurological TB. So TB mostly, of the lungs. Now, by just having a patient who presents with focal signs with an abnormal chest X-ray, you're already thinking this is probably, TB. And you can see that some of them had syphilis, and syphilis can also present with focal signs depending on how bad it is. When you look at your LP CSF results, the majority had a significantly high protein, raised white cells, and then 6% had TB, 3% had crypto. And you saw in the differential when I asked you what is likely, no one, for some reason, no one thought crypto is a possibility. You should never forget crypto in a patient who's got a CD4 count less than 100, right? Quite important. And in toxoplasmosis, 3%. Right there, the majority had very low CD4 counts, and you can see they presumed. That's why I'm asking, what is your clinical suspicion? It's very important because your clinical suspicion determines the investigations. It also determines the empiric treatments that you are going to give. You can see in most of these cases, the presumed cause, presumed it means before the test and you get the test results. TB was most likely to be suspected, neurocysticercosis second, and then you can see toxo, and then multifocal progressive multifocal leukoencephalopathy, and then the CNS primary CNS lymphoma, 3%, and some infarcts, and mixed, quite common actually that any of this. So that on that question, when I said more than one condition is likely, you must remember that almost 13% of all your patients would have comorbid causes for their focal neurological lesions. So this is quite important. I liked reading this paper, and I will share it, I think, when I share the slides and the recording. Just go through it. It's quite empowering in terms of understanding issues of the CNS and imaging. In terms of types of lesions, most patients presented with multiple lesions, mostly affecting the cortex, and then the majority had the sort of thin walled. So if you know about your neurosister psychosis, tends to have thin walls rather than thick walls, but thick walls equally quite common, for irregular lesions, and that is where you should be thinking some of the bad infections or even malignancies. Most lesions were hypodense. That means they looked a bit darker than the brain itself, and 63% were ring enhancing lesions, right? So ring enhancing lesions that are dark for some reason. I think I'll ask also Dr. Tebe to comment on this. And you can see as well, meningeal enhancement was only positive in around 53% of these cases. And usually meningeal enhancement goes together with TB because it's got something to do with exaggerated inflammation, which you don't get with conditions like crypto. Dr. Tebe, I don't know, this slide, would you like to clarify some of the language so that clinicians can also learn?
Hello, can you
Yes,
hear me?
nice and clear.
Okay, yeah. The pattern, we look at the characteristics on the CT. I think maybe they were looking at the CT, that's my assumption, because if it was MRI, they would have mentioned intensity hypotension. So what we look at, like you are saying here, they are looking at different patterns like basal meningeal enhancement. It's where you look, I think you have images later on where you'll see the pattern when we say basal meningeal enhancement. We do a pre and a post-contrast CT, and then on the post-contrast, you'll see enhancement along the meninges, and then that's when you start to see that this is definitely meningeal enhancement, and especially around the basal systems. And then sometimes you can even find that you have ring focal basal, is it focal brain lesions, like where you have ring enhancing lesions like the one you have just shown now of that case of toxo, that we call it the ring enhancing lesions. Because, and then we can have nodular also. I hope you have as you go on, like where you see a solitary lesion that enhances homogeneously. You don't see anything like in the ring. It's just like a ring where you see that it's in the periphery, the enhancement. But when we say it's nodular, it's like a solid thing that is enhancing. And then the gyriform is when it's following the pattern of the gyri. Then hyperdense and hypodense, it's when it is high, then we say it's hyperdense. I don't know whether does that make sense.
Yes,
sometimes it's better when you show with images to show these things.
Yes, we are getting there shortly. So in the same publications, they then looked at the outcomes. So you can see that most patients made it, and I think it's probably because of they suspected, if you look at the presumed causes, generally it was TB, and then most of the time after doing the tests, TB was also the correct diagnosis. So the presumed cause is quite important, because if you get it right, it means you would be in a position to initiate treatment timely and ensure that the most patients are managed correctly, right? So you can see that in South Africa, generally, the top three conditions that are quite common when you see an HIV positive patient with a focal neurological lesion, especially patients with CD4 counts less than 100. Your top three really, it's TB, it's toxoplasmosis, and neurosister psychosis. So if you see a patient tomorrow in the middle of nowhere, and really you think a CT scan will take you a week, what can you start treating whilst you do your investigations? It's TB, toxoplasmosis, and neurocysticercosis. And if you get it right, most of the time you are likely to get good clinical outcomes. And you can see that except for TB, remember, it can still happen at very high CD4 counts, but at low CD4 counts, patients tend to get disseminated extrapulmonary TB, neurocysticercosis as well, very wide in terms of the range, but the rest of the conditions, you'll see that they tend to happen at very low CD4 counts. So be wary of patients who start ARVs late, and for one reason or the other, it tends to be males, and that's something that we need to look at. So just to take you through some of the important algorithms. So how do you approach a patient who presents with a headache and meningeal signs, right? One is to assess whether there's a contraindication to a lumbar puncture, right? If you think there is a contraindication to a lumbar puncture, then you have to start empiric treatment and maybe make some referrals for a CT scan, do your blood cultures, then adjust your treatments based on those findings, right? Because remember, if you can't do a lumbar puncture, then you have to follow and try and treat things that are quite common. If there are no contraindications, it's always a good idea to then do a proper assessment of your patient, do a lumbar puncture. Today, you can also do a serum crack antigen, do your gram stains, do your urine LAM. These are tests that can give you quick results and really help you to shape your empiric treatment for your patients. So obviously, if the crack antigen or Indian ink comes back positive, we have to treat for crypto. If AFB, TB expert, or the other TB culture comes back positive, you treat for TB, and then hopefully from your gram stain and your blood cultures, wherever you can get as well, you treat. So remember, if there are no contraindications, really, a lumbar puncture should be done. We shouldn't get used to just shooting and not knowing what we are trying to treat, right? So if a patient presents now with a focal deficit, like our case, right, and without any meningeal signs, so we don't think there's a meningitis, but the patient presents with seizures or even a facial palsy, things like that, and you have no access to a CT scan, right? You have no access to a CT scan. You have to do a proper clinical assessment, but also trying to assess whether there is raised intracranial pressure or not. So are the pupils equal or unequal? Is the papular edema? Does your patient have projectile, vomiting? Because if your patient has any of these three things, it means whatever is happening in the brain is quite significant, and it is recommended that you start something like dexamethasone. You treat, with antibiotics. You treat the top three things: bacteria, toxo, TB, and then depending on other things, you might need to treat for cysticercosis as well, and then if your serum crack antigen comes back positive, you might want to treat for crypto as well. And if your patient recently started ARVs, it might be best to stop ARVs, because remember, if you get an exaggerated inflammatory response in the brain and there's raised intracranial pressure, there's a huge risk that your patient would actually cone from that, right? Now, in the other side, you don't have access to a CT scan, but clinically, your patient is stable. You don't see anything that tells you that there is a raised intracranial pressure. Then you are allowed to do a lumbar puncture. So you don't always need a CT scan to determine whether you can do a lumbar puncture or not. Clinical assessment in a rural setting quite important. And if you manage to do your lumbar puncture, you would then manage your patient according to those results. So I will share this slide with these algorithms, and I hope that you find them quite useful, right? So this one, it's a focal neurological deficit with meningeal sites. I don't know, my Zoom thing is hiding the sentence there. Okay, yeah, without, yes, focal deficits without meningeal signs, but you are in Gauteng, in Steve Biko there, and you have access, you know, to a CT scan, or Witbank Hospital, Robs Ferreira, you know, the big hospitals there. So here, it's a question of do you suspect a space occupying lesion or not? So even a CT scan is not indicated, right? Unless if you suspect that there's a space occupying lesion, then you do a CT scan, and what you're looking for is a mass effect or a midline shift. And maybe Dr. Tebe will also add to that. But all in all, you have a patient who presents with, like our patient, without meningeal signs. CT scan is available. If there are no obvious signs that there is a space occupying lesion, you could still do a lumbar puncture for our case scenario and then manage based on the results. But if you are very fearful and you think that, hey, I might cause more harm than good, then do your CT scan. And then if there's a mass effect or midline shift, then you treat empirically. If not, do a lumbar puncture and then treat based on those results. Dr. Tembe, does this algorithm make sense for you? Do you think there are scenarios where a lumbar puncture could be done for a patient who presents with focal neurological deficit? What's your experience around that? Thanks.
Hello.
Yes, Dr. Tebe, very nice.
Yes, I think the algorithm is good, the way, the approach that you have to look for that. And then the other thing that I need to add, because this is always what we come across, CT scans role in patients without, where the patient has focal deficit without meningeal signs. It does play a role when you're looking for, even in case where you suspect the patient has meningitis, to rule out the complications. Yes. The role of CT scan in a patient, because usually we find that they send the form and say, this patient query meningitis CT scan. If I do the CT scan and the CT scan comes negative, what are you gonna do now? Because a CT scan can come negative even when the patient has meningitis. The role of CT scan is mainly if you have mentioned that you're suspecting patient has brain edema, then you don't want to do lumbar puncture. You want to first rule out if there is no herniation. So then you can then say you want to do the CT scan. But if the patient really, you're suspecting meningitis, you better start your treatment. The role of CT scan in that case, it's when you want to exclude the complications of meningitis, like when you suspect patient now is hydrocephalus, cerebritis, and all those other accompanying complications. And even in the case here where you want to look at when the patient has focal neurological symptoms, you then want to look at focal lesions in the brain.
Yes. Great stuff. Great stuff. Yeah, colleagues, please do share your comments and questions in the chat there. I'm learning as much as you are, and it's just exciting. And here is another very nice summarized algorithm, which would be very helpful also in terms of, how do you go about deciding, which tests to do, but importantly, what to treat, And you can see here, it says, if you are looking at your imaging and you find that either there's multiple or solitary lesions, the most easy thing to do sometimes is to do your toxo antibody test. If that antibody test is positive and you have done a chest x-ray, the chest x-ray has no signs, clinical signs of TB, most likely you want to treat for toxoplasmosis, right? And then monitor clinical response for your patient. And if there is good response, there is no further workup really for that patient, depending on your clinical assessment of the patient. But you would see that if you treat for toxo and your patient is not improving clinically, there might be a need to either do further studies, but also consider doing a biopsy to see if there's something else you are missing, right? This is for multiple lesions, but don't forget neurocystic psychosis as well, in this context. Now, if you are dealing with just one solitary brain lesion and your toxo antibodies are negative and you think TB is also unlikely, this protocol recommends that a patient gets a PET scan, and then if it's hot, you are thinking this is probably primary CNS lymphoma, which is a common thing for patients with CD4 counts less than 50. If it's cold, then it tells you you're not dealing with malignancy. You need to probably still look at further, infectious or cold kind of things like crypto. Maybe you need to look for TB somewhere else, maybe even a biopsy, treat for TB or even treat as toxo, depending on how your further investigations would come through, And the other thing is to look at if there's no multiple or solitary lesion, but you find that whatever you're looking at is confined to the white matter, so the gray matter is preserved, there's a white matter disease. In the context of HIV and a low CD4 count, you are thinking, could this be progressive multifocal leukoencephalopathy? So encephalopathy, leuko means white, where the white matter, has been affected, usually linked with JC virus, for those who are going to write the diploma. And really, if PML is confirmed, there's no, as far as I know, there's no best treatment for that except to start ARVs in those patients. Some of them might recover, some of them might not recover. Otherwise, if a brain biopsy is probably the ultimate thing, but we know that access to such kinds of things is a bit limited with neurosurgeons. Certain provinces don't even have a single neurosurgeon right there. Dr. Tebe, this one, what's your take? Are there specific takeaways from this algorithm?
One thing I can add there at the beginning of your algorithm, where they say like the lesions, if it's multiple, you think of toxo, and then if they are solitary, it's TB. I think if you look in our setup, TB can, even CNS in the brain can present in different way when we do imaging. You may find that you have a tuberculoma, where you have just a solitary enhancing lesion. And then you can even have TB abscess, where you just have rim enhancing lesions. And remember, in HIV positive patients, it's not always that the patients will follow our normal textbook. TB can behave very bad. You can find that you have multiple ring enhancing lesions and then they come TB. Or you find that your patient, you have done the test for the toxo, so it's negative, or you have even started treatment and the patient doesn't respond, then you start the TB, then suddenly you see the response. So I think the other thing here is to also do concurrently with assessing your clinical response to what you have started on the patient.
Great stuff, because I do
sometimes
see cross here.
Sometimes TB can even just present as TB meningitis, as you have mentioned earlier. And even in some instances, it can even present as just a stroke, where you have just TB vasculopathy, where then you suddenly have a patient with an infarct, only to find that the vessel that is involved was infiltrated by this exudate from the TB, and then suddenly you develop the thrombus on the vessel, then suddenly patient develop a stroke. TB can,
That's TB for you. Thank you for that. That is quite helpful. And yes, and I think this crisscross here sort of reminds us that if you have to really treat more than half the time, you might end up treating, for both, especially if you don't have time and you're dealing with a very sick patient, because you can see if they are not responding to TB, the recommendation is consider treating for toxo. If they are not responding to toxo, consider treating for TB. So quite common, both conditions right there. All right, great stuff. Maybe before that, in terms of the lymphoma, what would be some of the clues that tell you that, no, this one, we need to look deeper, and maybe it might be a primary CNS lymphoma, a malignancy there?
Hello?
Yes, yes, we can hear you. Thanks.
Yeah, for primary CNS lymphoma, usually commonly the lesions you find that they are solitary, and then you can even have multiple lesions, but they have predilection for being in the periventricular area where they affect the white matter regions.
Great stuff. Great stuff. No. Superb, superb. And most likely your antibodies would be negative. You would not have clues for TB. And even if you treat for both of these, you might not get a good response. And you should be thinking then of a third condition in addition to other things as well. Yeah, interesting. All right, great stuff. Yeah, so quite a number of tests. Really, if you have a mass lesion, you might need to do blood studies. Like someone said, you must do an FBC, exclude syphilis, toxoplasma antibodies, check the CD4 count. It will really help you with your differential. If your patient is on ARVs, you want to see if those ARVs are working. Then you can also do your CSF studies, checking protein, glucose, your cells, syphilis again, cryptococcus, TB, excluding TB, additional things like your IgG for your antibodies in the CSF, anti-polymer fluorescent antibodies. So quite a number of other viruses as well, CMV, Epstein-Barr, HSV. If you find JC, Papova virus, then you think of PML, where the white matter is going to be significantly affected. And radiologically, a chest X-ray is quite useful to exclude, especially TB, and then some of the more advanced scans as per the advice really by radiology. So yeah, so you have to take proper history, you have to examine your patient, you need to know some of the easy tests, your urine LAM for TB, your TB gene expert, blood cultures. All these things, when they come together at some point, they will give you some guidance. And ultimately, which is not included here, there might be a need for a biopsy if you are not finding your solution very quickly, So for a patient who's not acutely ill and who do not have, your toxoplasma is negative, most likely you are thinking of TB. And really, you can see the thinking, it's always around toxoplasma and TB, but don't forget the other things as well, cryptos and so on. Acutely ill patient, toxo is negative. Could you be dealing with TB? Some patients will might still have toxoplasmosis, because remember, some of these antibody tests, they also become weak in very significantly immunocompromised patients, especially if your CT shows you more than 6 lesions, small multiple lesions, you need to say, okay, can it be, in a patient where toxoplasma is positive, yes, you treat for toxo, but depending on your clinical findings. So you can see it's all about deciding between toxo and TB. But all in all, the top 3 things, toxo, TB, and then neurocysticercosis, which is a parasite. And I think this is a topic which is next to talk about the intracranial mass lesions in HIV from patients in our setting, where there are regions really where they are endemic for neurocysticercosis for patients who had a tapeworm. Dr. Tebe, this is where you come in. There's our thin-walled lesion there. I think it's hypodense, but yeah, let me hear from you. Scopex and all those things. Thanks, Doc.
Okay. One thing again about the neurocysticercosis, if you remember the stages, it has different stages. Remember, you have a vesicular stage, the colloidal, vesicular, the granular, and then it can ultimately calcify where it's in the late stage of nodule that has calcified, and you can just find the granuloma. And this is another dilemma, that when you have it already calcified, can you tell whether it's TB, calcified TB granuloma, or is it a neurocystic granuloma? It's another dilemma we always come across on a daily basis when it comes to this imaging. And then looking at the stages of neurocysticercosis, the most common symptomatic stage usually is the colloidal vesicular stage, where you find that there is associated edema. When you look at the first image there, where you have, it's your coronal MRI, it is the T2 sequence, sorry, it's T2 sequence. And then when you look at that, you see just the area of hyperdensity, which is edema that is surrounding the lesion. And then the next image that you see there, where you have this ring enhancing lesions, it is where you have given contrast on your normal T1 image, which has been given gadolinium. So you see ring enhancing lesions, but you don't see much of that edema. So when we do MRI, we have different sequences that we know that this one, like a T1, T2 the imaging, we know that when you do the T2 sequence, mostly you're looking at your edema, things like that. And then when you do the T1 with contrast, then it can definitely show you the rim enhancing lesions. So then this is most likely then if it's neurocysticercosis, you will suspect most likely to be the colloidal vesicular stage, where you have a cyst which is surrounded by the edema that you have seen on the first image. And then later on, when you go with the granular stage, edema start to decrease, but the enhancement is the one that will persist. So what I can say, maybe looking at these two, if they were taken a different stage, I will say the first one is showing the colloidal vesicular stage, where you see a lot of edema. And then later on, you don't see much of the edema, but what you see much of the rim enhancement. And again, with looking at these images, again, if I have to challenge you, can you definitely, by looking at this imaging, say this is neurocysticercosis? Or can this be TB abscesses? You cannot.
Yeah.
And then the other thing, I beg your pardon?
Is there a clear differentiation between neurocysticercosis and toxoplasmosis on imaging? I mean,
remember we said the toxo, you can have also some multiple lesions.
Yes.
And then even the neurocysticercosis, you can still get multiple lesions. Imaging becomes difficult if you're not given enough clinical picture where you can correlate the two. And the other thing, as you say, you still have to do some serology testing to check for the toxo, whether it's negative. And then one of the other thing I used to hear from one of the old neurologists, he used to say, have you checked the muscles? When you see a patient like this, if you're suspecting a neurocysticercosis, he says just do one of the limbs X-ray, and then you see these calcifications like basmati rice on the muscles there. Then they'll just say, this is definitely a neurocysticercosis.
Nice. Colleagues, let's go and write. Thank you, Doc. Yes, okay. So from the same Jomek article, they put a nice, they say they usually present with regular, so not irregular, regular thin-walled cystic ring enhancing lesions, often with escolex, you can get intracranial calcifications, which is later on in terms of the cycle. And then you might get a positive blood or CSF sorology. So usually they do an ELISA antibody test, and it might come back positive. However, a negative test would not exclude neurocysticercosis. So that is quite important as well to note on that point. So I don't want to go through the rest. We'll come back to the treatments. So other things which, even when I called you, Dr. Tebe, which we discussed some of the, HIV encephalitis, where HIV itself, can infect, the brain, but we know that you can get viruses like CMV, you can get the HSV causing an encephalitis. I don't know if you would like to comment on some of the viruses and causes of encephalitis that we need to also think about. Dr. Tebe,
Hello.
Yes, we can hear you
Hello.
now. Sorry,
Oh,
yes.
it was breaking in.
Yeah, I think it was mute, yes, but we can hear you now. Thanks.
Okay, you were saying something about?
Yes, I was saying HIV itself can cause an encephalitis, so HIV, but I was saying there's other viruses as well, CMV, HSV, herpes simplex virus, cytomegalovirus, which can also cause an encephalitis. And I wanted you to share either your experience. Yes, thanks.
Okay. Yeah, one of the things commonly that you can even get is this you call HIV encephalitis, which we even call it mostly HIV-associated dementia, because usually patients present with dementia.
Yes.
That is what usually, it's HIV-associated dementia or HIV encephalopathy. So usually I think the clinical symptoms are the ones that will also lead you if you're dealing with HIV, dementia, or other infectious conditions, because this one, you mainly have a cognitive or impairment, behavioral dysfunctions, things like that. And that will also lead you to think that, am I dealing with HIV encephalitis or PML, that may be reactivation of JC virus? But on the imaging, then interesting, this is one that is far much better, that you cannot commonly confuse it with others. HIV encephalitis, as I have mentioned, that you can have cognitive impairment, that is, you'll find it when you do your clinical exam. And then when you do your imaging, you find that usually you have diffuse symmetrical atrophy. So as you see in your picture here, it is an MRI, a flash sequence. You see that already you have a bilateral periventricular deep white matter hyperdensities that you see there on both sides. So it's bilateral, and then it's symmetrical. Both things that I have already mentioned, being symmetrical, already start to make you not to think of PML, because both PML and the HIV encephalitis can give you bilateral. The other one may not be as symmetrical like this one. And then the other differentiating, the HIV encephalitis, as you see here, it has affected the deep white matter, the periventricular region, whereas the PML will also affect the subcortical white matters, giving you picture like the U fibers. I think you have a slide that will show that one, how you differentiate the two.
Thank you, Dr. Tebe. You need to come back. I don't think today we're going to have enough, but yeah, I'm really enjoying this as well. So yes, so toxoplasmosis, generally happens when the CD4 count is less than 100. So it's a clue. The lesions tend to be hypodense. They tend to be multiple and ring-enhancing lesions with edema as well, with basal ganglia and gray matter zones sometimes being affected. And then generally, really, you generally confirm your diagnosis when the patient responds, to treatment. Generally, if they don't respond to treatment, you start to think that maybe there's something else you might be missing. I think toxo, we discussed it a lot. Again, toxoplasma with an encephalitis as well. And you can see that the lesion there, I don't know if there's a midline shift. I think so, towards the left.
Yes.
Dr. Tebe, you'll
to the right side, yes, there is already midline shift. And then if you see that the left frontal horn of the lateral ventricle is already compressed, when you compare it to the contralateral right side, it's smaller. So it's smaller due to this mass effect caused by these lesions.
Yeah, so colleagues,
and it's not even one. Can you see it's multiple lesions there? There are some that are just
there.
Yes.
There.
Yeah. So it's multiple lesions with that bigger one that is rim enhancing.
Yes, yes. Would I be correct to say there's edema around there, or how would
yes, that is edema.
Yes. Yes. All right. All right. Great stuff. And what about some atrophy?
In this one, on the contralateral, the right side, I wouldn't really say there is atrophy. Remember now, on the left side, you have mass effect that has caused edema. And then on the other side, it's not really atrophy what you're seeing. Okay. Are you thinking now of HIV encephalitis when you're asking about atrophy? Because you get it mostly.
Yeah, I'm just linking the encephalitis part of the diagnosis here. I'm thinking.
Yeah, it can be just the inflammation. Remember the encephalitis. Yes.
All right. Great stuff. Great stuff. Great stuff.
Because remember,
yes.
Yeah, remember with what I said with HIV encephalitis, you get atrophy at a later stage, which will be out of proportion, like with the age of a patient. You find that this patient is so young, but the brain has shrunk, and then that is later on the HIV encephalitis itself, what it does to the brain.
Great stuff. So in terms of evaluating this, there's an obvious midline shift, right? And when we talk about mass effect, are we talking about the size of the ventricles? Are there other things we are looking at?
You're looking at the hypodensity around the lesion there. It has caused the mass, the pressure it's putting on the area there. You can't even comparing to the right side, the same area, you can see nicely the sensation there and follow the gyri. But on that side where there are lesions, it's just hypodense. You can't even see the sulci and gyration, so it's effaced. It's because of the mass effect by the lesion.
Nice, nice. I shall be smarter. Hey, colleagues, I think we are all learning together. I'm enjoying this. Yes, so primary CNS lymphoma, like I said, Dr. Tebe said, generally solid or solitary solid lesions. And you can see now, rather than to say hypodense, we're talking about hyper dense. So this might be a little bit bright or white, with no edema. They tend to be homogeneous. I think that's why we say solid mass of some sort. Generally happens at low CD4 counts. You might get also abnormal lymphocytes in the CSF. I tell you, I've diagnosed these as a very young HIV clinician by just asking, even if I didn't know much about CT scans, by just asking for Epstein-Barr virus PCR on the CSF. And whenever I got positive results in a patient with focal lesions, then I knew that we are on to a primary CNS lymphoma. And these patients, you see now, the clinical part, your response to treatment gives you the biggest clue really. If your patient is not responding to both TB and toxoplasmosis treatment, you should be thinking, am I dealing with something else serious? Yeah. Dr. Tebe?
Yes. I see you have put cerebral toxo next to it. I think you were just trying to compare. If you look at the two images, the first one, you don't see much of a mass effect or edema. As you have mentioned that you don't get much of edema when it's CNS lymphoma. But looking at the second slide there of your cerebral toxo, there is a lot of edema there, that hypodensity surrounding the lesion, it's edema. And even if you look at the ventricle already, there is some mass effect. You see those two slits of the ventricles.
Yes.
Yes, they are asymmetrical. The left one, you can still see. This one, the right is narrowed. It's all the mass effect caused by this toxo lesion there.
Yes. And I've just learned from you that the gyre you see here can follow the sulci and gyre this side. I can't see much. They are more reduced. Great stuff. No edema and then hyperdense. Yeah, right. Great stuff. CMV encephalitis, and I think that's what I was referring to, that some of the viruses, HIV itself, CMV, HSV, they tend to also cause an inflammation. And then, yes, can we talk to progressive multifocal leukoencephalopathy? I can never describe it, but I just know how it looks when I see the CT scan. I just see a whole lot of white. Then I know that, okay, this is PML. And
can you
obviously,
go back to see, sorry for this,
this
can you
one.
go back to
Yes.
to
Yes.
the yes, this one, the encephalitis CMV virus. Remember, you can have a lot of infections like caused by the viruses, and then so one of them is CMV, where you have CMV encephalitis. So usually, even these ones, the presentation commonly can also be cognitive decline. So then what we can say that majority, when you have cognitive decline or impairment, you think of CMS, cytomegalovirus encephalitis. And then remember, I also mentioned the HIV encephalitis itself. So with CMV, what you're seeing, you can even get meningoencephalitis or ventriculitis, where in this case, the image that you see there along the ventricles, you see there are those white things outlining. Then it's enhancement of the surface around the ventricles along there. So that is how ventriculitis look like. So when you have ventriculitis like that in a patient with a cognitive decline, you will then think more of a CMV.
Empowering, yes. And I was about to talk about the PML, slow mentation. I've seen these patients, very low CD4 counts. They can't even take care of themselves more than half the time. Slow mentation, cognitive impairment. I usually used to do a test where I just give the patient 3 items, whatever I have on the desk. And then after some few minutes, I wouldn't even wait minutes, seconds, then I ask them, what did I show you? Half the time, they would not remember those things. And then you ask your patient to say, here's a bottle of water, take this bottle. I tell you, they have psychomotor retardation. The patient might even take 5 minutes just for the hand to move and get closer to whatever you are asking them to touch. It's actually very, very, very bad and horrible. They also have apathy, but some of them improve on ARVs, some really never improve. Yes, Dr. Tebe, you may take us through this one.
You remember I said when HIV encephalitis and PML, you need to be able, the two always can confuse you, but there are distinguishing features where I said with HIV encephalitis, usually they are, lesions are symmetrical, although they are bilateral. And with PML again, it's bilateral, but not symmetrical. And I said PML, the other thing about it, it likes the subcortical white matter. So in this case, and also, it can affect the parietal, occipital, or the frontal. Like in this case, here you have the subcortical frontal U fibers that are involved. When you look at the second image, because the first one, it shows mainly edema. When you look at the second slide, you see on that, when you compare the right and the left side, they are not similar. Yes. The left side is more involved than the right. And then if you move your cursor around the margin there, you can follow that this is following a shape of a U on the fibers. It's just that my cursor is not active.
The U on there?
The U fibers, subcortical. This is the hypodensity that you see there.
Yeah.
It's in there. That black, the black thing in the front. Yes. That is where there is involvement. Compare this with the occipital area. You see the occipital area, you see your gyri and the sulci, it's nice, it's normal, it's still fine. These ones, where you're going there, it's still fine. And then remember the subcortical white matter that you just see around there. So when you go back frontal there, you see this black thing there. Yes. So this is involvement of the subcortical white matter. And it's asymmetrical. If you compare this left side and the right side, you see that the right side, there is asymmetry. So this goes more for a PML.
Great. Great. Colleagues, lesions confined to the white matter. You get hypodense, non-enhancing appearance, on the MRI scans, and there's no mask effect, which is quite important. The giveaway really is if you do a PCR on your CSF and it comes back and says JC virus. But clinically, I can tell you most of these patients have some serious encephalopathy, like I've explained, the slow mentation, psychomotor retardation, apathy, gait, they can't walk on their own. They need people to help them. If you see such patients with low CD4 counts, do that PCR test, get the CT scan if you can, and then I think it will be a great clinical learning experience as well. Because you can see I can only refer from my clinical experience, not as a specialist, but just from the patients. You must always be in pursuit of a diagnosis, because when you do finally get the diagnosis, it is such a great learning experience. You'll never forget these particular cases. And I'm happy that Dr. Tebe did mention that TB has got so many phases. It can present as a solitary lesion. It can present as multiple lesions. It can present as an abscess. And in our setting, it's probably one of the most likely conditions to treat. It's always a good idea to look for it outside of the CNF, whether doing your sputums, your gene expert, your TB, BACTEC cultures, ADAs, those things are no longer very useful, but your urine LEM test as well, quite useful. Maybe, Doc, if you can summarize for us issues of TB, but I think we are seeing some pathology there.
Yeah, on this one, you're seeing multiple ring lesions that are enhancing in the central part, although there is a dot that is black, like hypodense. Maybe it's the necrotic part of the tuberculoma. It's not the abscesses, these ones, because the abscess usually get a rim enhancing a peripheral rim that is usually regular. This one, it's just mostly like it's a small nodule that is enhancing the central part. Maybe it's caseating, it's TB, because others are still nodular just on the right side. If you see, there's one that is just a dot.
This,
yes, that one. So some then, so it is tuberculomas, these ones. But I must say, if you were to give me this scan like this and tell me this patient has breast cancer and all that, I will definitely say this is metastasis. That's why its history is very important.
Great. Yeah, we are all learning, and I see the dots. I see all these. Yeah. Is it similar to? I mean, is this similar to miliary seeding of TB? Most likely from the chest and then seeding as well the brain. Yeah.
Yes. Right. Yes.
Great stuff. Thanks.
Because the miliary, then you just see this millet like that are multiple. There is another abscess. Look how irregular the ring is there. It is a regular rim enhancing lesion there, unlike the one we just saw previously. So this one is a
patient. I think it looks very.
I'm not a clinician. I just see the images.
All right.
It will depend how soon did the treatment started, and did the patient respond to treatment? Is it resistant? You see, so many factors.
Yeah, and I mean, this is quite serious. And you can imagine, colleagues, if you were to start ARVs on this type of a patient and they get this exaggerated inflammatory response, this patient might not survive that. So maybe that's the value of doing a CT scan, right? Trying to figure out what am I dealing with, where is it, what is the size, and ensuring that before you start ARVs in the first place, this is treated as effective as possible. So quite important right there. Yeah, cerebralitis as well from TB. So you can see TB can affect everything really. You know, I don't know if TB can affect the hair, but I think TB is a huge problem right there. We're about to sum up, colleagues. I know we are behind time, but I was enjoying this session. Doc, can you, this one says vasculitis. What are some of the key features there?
Okay, on this one, it's an MRI, a coronal. So what you're seeing there is a flare sequence fluid attenuated invasion recovery. So where you're seeing a high areas, high signal areas there, or high intense areas in the cerebellar peduncles. So and I'm sure it was not the only sequence they have. They must have done other sequences, diffusion and all that. So this is definitely then, because you're just seeing an area of a high signal, I'm sure there were a couple others. So with that, then the conclusion will be that it's an area of infarction. Probably then the TB has infiltrated one of the branches of the bacilla branches that supply the cerebellar peduncles, and then this resulted in this an infarct in that area.
Great. Ayandiswa, you should let me know if your hand is truly up, you and Mikey. Later on, I will give you a chance. And then what I know about crypto is that you are unlikely to see anything sometimes more than half the time, because patients don't have immunity to respond, versus TB meningitis, where you might get meningeal enhancement. Unless if there's an obvious lesion, a cryptococoma, something like that. But the giveaway really is a CD4 count less than 100. Your serum crack antigen is positive. Your patient presents with focal neurological deficits, and then you then think of it. You might also find the same in the CSF. I don't think there's anything obvious in this image, Dr. Tebe.
Oh, it's muted. Oh, this one, if you look at that image there, it is a post-contrast CT, MRI, sorry. It's post-gadolinium. So you're seeing enhancement along the meninges. That those wide areas that are going in, then it's, and especially if you look at on their left side, comparing there along next to on the posterior fossa along the CP angle. Come down. Yes, go in, follow this line. No. Yeah, no.
Up.
Come up again. No, up.
Yeah.
Go in, follow the inner black line.
This one.
Go down. I think I should have had my mouse active. Come down.
Keep going down. Yes.
Go towards the right.
Towards the right.
Yes. Go down. Yes. Okay, go towards the right side. Right where you are. Yes. If you see that those enhancing areas there, if you compare the same, if you compare the same area on the right side, there is you see it's not similar. So this is what we call like it's meningeal enhancement around there.
Yep.
But now it can confuse you, because even TB can give you meningeal enhancement.
Yeah.
So then the clinical and the laboratory confirmation, it's where you comes in, where you need confirmation, unless then the patient, sometimes you can have, remember cryptococcus can even present with parenchymal lesions where you get cryptococcomas, and then sometimes you can even have the perivascular lesions where you have those pseudocysts.
Great.
But in this case, it's just the meningitis, meningeal enhancement. Here it is. There you have your pseudocysts, your cryptococcomas, those hypodense things there next to the basal ganglia, and even, look how it has compressed on the ventricle. Actually, I have seen several of cases like this in the centers where I've worked, and they respond when they are given treatment. After a few months, you redo imaging, you find that the lesions are resolving.
Dr. Tebe, thank you. So colleagues, as we close this, I know we are a little bit behind time, but yeah, coming back to our case of a 40-year-old man who presented with seizures, he's positive, the CD4 count is 32, he's not on ARVs, not on Bactrim. Remember, neuroimaging revealed that he had some numerous temporal frontal ring enhancing lesions, a very high pleocytosis or high white cell count in the CSF. Everything else seemed negative except the high protein, low sugar. The chest x-ray was clear. So you see, in terms of the algorithms we discussed, if the chest x-ray is clear, we sort of want to say there's no TB, but like I said, for your significantly immunocompromised patients, a chest x-ray is not very useful. So you might have to look at other things, symptoms, urine lamp, and then we take it from there. Jabulani, I'm going to take your hand. We discuss the differentials, the investigations. I just want to give you more information about the case. So the PCR for Epstein-Barr virus was positive. I would have liked to see what you think the diagnosis is. TB was negative. Cytology was negative. Serum and CSF crypto antigen was negative. The toxoplasmosis IgG was positive. And then also cysticercosis ELISA test was positive. So because of time, I'll just tell you my thinking. My thinking is that the patient probably has toxoplasmosis and has cysticercosis as well, neurocysticercosis. So we need to treat both, but we should be concerned about the Epstein-Barr virus in there. Once we have treated these two, if he responds, we need to look further to see if there's a need for a biopsy or further investigation in that context. So the patient did receive a toxoplasmosis therapy, anti-epileptic agents, and heart. Unfortunately, because of health systems issues, the patient was lost to follow up. This is another nice algorithm to say, are you dealing with a cystic or solid region? If it's cystic, thin-walled, very nice, you think neurocysticercosis. If it's a solid lesion and it's enhancing, maybe it's a meningitis from TB. If there's no meningeal enhancement, it might still be other things like your toxo, PML, like we have discussed. The only slide which I jumped intentionally is around just summarizing at the very high level around treatment to say if it's TB, we still treat, with normal TB treatment, but it will be regarded as extra pulmonary TB. So we need to treat for a longer duration. Toxoplasmosis, you treat with high dose cotrimoxazole. And then neurocysticercosis, it's a parasite, so albendazole tends to work. Cryptococcus, remember, dual prophylaxis, but you can also use 5-alpha flucytosine instead of fluconazole, and patients can recover quickly. You can actually treat them just over 7 days rather than 2 weeks if you can replace fluconazole with 5-FC. And then if it's neurosyphilis, penicillin still works. And then remember, ARVs, only start ARVs once that opportunistic infection has been treated right there. Dr. Mkhwanazi, you've got the volume there. Would you like to say something? You may unmute, Dr. Jabulani. Dr. Mkhwanazi, are you there? I see your hand. Please unmute. Your hand is up, Doc. Okay. I'm not. Oh, yes.
Yes. Good evening to everybody.
Thanks,
Thank you, Dr. Mawela and Dr. Tebe, for a wonderful presentation. I needed to find out, man, there's a lot of confusion now with the treatment of TB. In the past, we used to know that if you're dealing with pulmonary TB, you just have to treat for 6 months, which is extra pulmonary, you treat for 9 months. So now we We've been sending patients to Witbank Hospital for CT scan, and they'll come back and tell us to treat the patient for a year sometimes. So with this confusion of MDR TB as well, being down referred to us district hospitals, it becomes a problem with us knowing when to treat and for how long, especially when it comes to TB nowadays. That's my confusion. Thank you, Doctor.
Yeah, so I can just share my experience. So there's no standard duration for extrapulmonary TB, right? And it depends on the severity of the disease, but also the clinical progress for your patient. So generally for a meningitis, I don't know, it is not 9 months, but it is a minimum of 9 months. And you can see if you look at a patient who's got an abscess very close to the brainstem, and you can see that it's very severe, you'll find that even that 9 months is not going to be enough for your patient to get a full recovery. In the context of drug-resistant TB, if it is confirmed that your patient has a CNS form of drug-resistant TB, I can tell you that the short regimen would not be indicated. Your patient will have to get a long regimen and a specific regimen for the CNS, trying to give drugs that can penetrate the blood-brain barrier very effectively. And the minimum duration is likely to be 2 years as well, and depending on what you are treating. So even if it's in the CNS, remember there's a difference between treating a tuberculoma versus treating a meningitis, you know, in terms of the severity and how bad that would be for your patient. So with extrapulmonary TB, it's all about clinical progress, and it's generally decided based on each patient and how they are presenting and responding to these treatments. So that's how you would approach it. Yeah. All right.
Thank you very much.
Thank you. Yeah. So yes, colleagues, this is it. This is the end of today's session. I know we are like 10 minutes behind time, but if you do have questions, please do type either in the chat box or in the Q&A as we close. Dr. Ahmed, you are saying neutrophils can be treated IV or MI penicillin G. It depends where. In the CNS, penicillin G would not be ideal. So something like Rocephin, you know, is probably ideal to treat any bacterial infections. Penicillin G would be quite weak in achieving good and quick results, Doc. So rather use something like Rocephin or even higher antibiotics if there's some resistance to that. Yeah, so great stuff. I hear you, Huawei. I don't know your name because your name is Huawei. The time wasn't enough though, yes, because we were engaging with the session, and I was hoping that it would interest you as I go through the slides for Dr. Tebe as well to highlight important things. But yeah, we'll share the recording, and you can also go through it very slowly, and then we take it from there. 2 more minutes. Any other comments or questions before we close this session, colleagues? All right. Great stuff. So I see that you seem to be okay. Yeah, on that note, just to thank you for always joining us on these HIV masterclasses. I'm hoping they are adding value to your life and to your clinical practice. Dr. Tebe, me and you, we know that I called you over a short notice, but I'm so grateful that you opted, you know, to join and to share. Sfiso Mota, you are welcome, my brother. I hope these sessions were worthwhile. Jabulani, how are these sessions going? Are you enjoying them? Should we continue? Give us quick feedback.
Thank you, Dr. Mayola. I think we should continue with these things. They are really informative, and with us working in different hospitals. Sometimes we are just out there. We don't even have this information. So thank you very much for this pleasure.
Great stuff. Okay, Dr. Tebe, any last words and then we close?
Thank you very much for inviting me to your sessions, and it was also quite indeed to hear from colleagues and on your side to share your data, and also hear from us the dilemmas we always encounter in radiology imaging, because sometimes it sounds like we are too fun when we say we want at least to have the clinical picture, but you have seen that at least the clinical picture also help us when we are dealing with the imaging. So this was actually a very, very helpful session. And I've also learned a few things from there, and that I will also take along. There is a lot I have learned today from your clinical aspect. And thank you very much for inviting me.
Thank you, Doc. Yes, we will be in touch. Colleagues, thank you very much. Good evening. Enjoy your evening. I will share everything with you. Thank you. God bless you.